Good afternoon, Miss Rami.
Good afternoon, my lord. My lord, our next witness is Rami Okasha, Chief Executive of Children's Hospices across Scotland.
Very much indeed. Good afternoon, Mr. Okasha.
Thank you. Good afternoon.
Good afternoon. Very good. Right, when you're ready, Miss Rami, on you go.
Thank you, my lord. Mr. Okasha, good afternoon. Thank you for joining us. Could you please tell us a bit about your own background and the background of CHAS, Children's Hospices across Scotland, please?
Yes, of course, no problem at all. I'm the Chief Executive of CHAS, Children's Hospices across Scotland. I was appointed and took up role just before the pandemic in February 2020. Prior to that, I had worked for CHAS for a year in a role delivering transformational change around services, and before that I was the Executive Director of Strategy and Improvement to the Care Inspectorate, where I was responsible for designing systems of scrutiny, assurance and improvement across all social care and social work services in Scotland. CHAS is a charity that supports children with life-shortening conditions. We provide unwavering care to those children and their families on every step of their journey, and that includes medical, nursing, social work, family support from hospices, in children's own homes and in hospitals in partnership with the NHS.
Thank you. There may be a perception among some that and you've addressed it somewhat in your answer there, but there might be a perception among some that CHAS mainly deals with children who have conditions and are at the end of their life, but that isn't quite the case. Could you tell us a bit about palliative care more broadly and the difference between that and end-of-life care, and the sort of durations that you are involved in children's lives?
Absolutely, and this is one of the big differences between palliative care for children and for adults. Often for adults we think about palliative care in the last months or perhaps year of life, but for children palliative care is understood to be from the point that a child is diagnosed with a life-shortening condition to the point that they die or indeed transition into adulthood, and that can take years. So often the families we are working with over an extended period of time, and the purpose of palliative care is to help children to live well and then to support them to die well when the time comes.
Thank you. Now, you have CHAS has two hospices. Do the hospices have both private and shared rooms?
No, all the hospices have single rooms for children. All of the rooms in both hospices are directly accessible to the outdoors, and when we got onto some of the practical issues around the pandemic, that became an extremely important point.
Great, thank you. You mentioned that one of the consequences of the pandemic was a reduction in bed capacity at the hospices. Why was there a reduction in bed capacity, given that the rooms are single rooms?
The main reason was the need to maintain social distancing, and the rooms are close together actually, and also the children who are there often are not just staying in their room, they are enjoying the experiences around the building, which is designed to be a homely environment. And so to maintain social distancing, we needed to zone the buildings to create spaces where families could be, and whilst we normally are able to support 8 families at any one time, during the pandemic we reduced that down and consequently increased the amount of care we provide in children's own homes.
Yes, and you say that the number of home visits doubled compared to pre-pandemic figures. How was CHAS able to meet that increase in demand for home visits? Well,
I think I'm not sure we were able to meet the full demand because the burdens of caring for a child who is very ill 24/7 are significant, and during lockdown many other supports came away. So I think there were many families who were not able to get all the care they might want. But we increased our care through the ability to flex our workforce, to ask our nursing staff to work in a different way and to work in the community. And I have to say that the flexibility and willingness of staff to go above and beyond to meet the needs of families was remarkable.
Great, thank you. And you tell us in paragraph 24 about the virtual hospice service that you started, offering both clinical and non-clinical support. Was the clinical support provided on a one-to-one basis, or did you have set sessions that everybody would attend?
No support from whether it was from a nurse, a doctor, or a pharmacist or another healthcare worker would have been one-to-one support. There were some group activity sessions for some of the things that were less clinically focused and more therapeutic based.
Yeah. So because we've heard from others, not children and not related to CHAS, that contact with clinicians and with other healthcare professionals just ended, and they weren't able to ask questions, they weren't able to have that contact that they had before. So you were able to facilitate that. How willing were the health professionals to work with you on that? How did you find arranging that? Because presumably the pressure on them to meet greater needs within a set time had increased as well. So how was that? How easy or straightforward was it to arrange one-to-one sessions?
Relatively easy from the point of view of the willingness of clinicians to support those, and what we did was we put in place a structured program of what we called kindness calls, which was really a form of triage, I suppose, which involved nursing staff contacting families that we support to just ask how they were and understand what they need and try to follow up where there was something identified. So that might be a family just at the edge who just needed a respite break in a hospice. It might be a family struggling to access a service that they hadn't otherwise previously done. And it was a way of understanding the needs of families. And I have to say that worked well. We were able to also, we had a number of staff who are themselves clinically vulnerable, and they were able to work in that way without exposing themselves to face-to-face care. So it worked well from both, I think, the perspective of the people using the service and the people providing the service. But I would say that it was not it was a poor substitute for the delivery of face-to-face care.
Thank you. And you touched on it there, you also had an element of therapeutic play. Was that an on-demand service that patients and families could access in their own time, or did you also have scheduled sessions for those?
Both, actually, and therapeutic play is a really important part of children's palliative care. With older people's palliative care, then often that is associated during a period of cognitive decline. With children, this palliative care is provided during a period of cognitive development. So enabling and facilitating children to learn to play and do what children do is hugely important. It's a core part of what would be considered good children's palliative care. So we were able to provide some of that support from our own staff. We have a team of activity staff within CHAS, and we also worked with other charities, including the Hearts and Minds charity, to provide some online clown doctor visits, which it was a way of providing light relief for families during a time of a lot of gloom and worry.
Thank you. And moving on from there, you mentioned that in order to support the impact of the pandemic on the NHS, CHAS stepped in to support the step-down care from hospital and stepped in to fill care packages that had collapsed. Could you firstly tell us what is meant by step-down care, and then tell us why these care packages had collapsed and how CHAS was able to step in to help?
Of course, so step-down care is where a child is in hospital and is able to come out of hospital but needs to be somewhere a little bit more supportive than home before they get home. So a child might have gone into hospital for an operation and be physically well enough to leave hospital but not physically well enough to be at home full-time. So our hospices are able to provide that level of step-down care with one-to-one nursing care under medical supervision. So that supports children to come out of hospital, because generally the last place anyone wants a child to be is in hospital. And in terms of packages of care, then many of the children we support have what are called packages of care in place. So that would be something assessed by the local authority, often delivered in partnership with the NHS, to provide very often a team of people to be round a child where they need 24/7 care. So that might be someone, for example, a ventilation worker who could support a child who was ventilated to be able to breathe and keep the airway clear. And certainly during the pandemic, that workforce was not all able to work. Some were clinically vulnerable, some became unwell, some had caring responsibilities at home. So there were children for whom the essential supports provided by the NHS or local authorities were simply not there. So we were able, in a number of cases, to provide nursing staff to both deliver care as part of that team around the child, and also train up newly recruited healthcare assistants who would be coming to work with that child. And we were able to do some of the training with those staff to help them understand how to care for a particular child.
And I mean, you mentioned that some of your workforce were clinically vulnerable as well. How were you able to prevent that from interfering in your ability to meet this gap that had emerged in the NHS?
It was very difficult, and particularly in the early days, there was a lack of clarity around which conditions or circumstances for an individual might be vulnerable. So I remember discussions early in the pandemic about the degree to which pregnancy was a factor that needed to be considered in deploying the workforce. And ultimately we tried to follow as much of the guidance and practice that health boards adopted in this regard, but also tried to have a really understanding approach, and were able to have one-to-one conversations with staff to understand their circumstances. And that was both the clinical situation of our own staff who were vulnerable, but also where they were at home with someone, living with someone who was themselves vulnerable, or where they had caring responsibilities which simply prevented them being able to do what they normally did. So flexibility as an employer was the key in being able to allow as many of our staff as possible to continue working.
That's very helpful, thank you. And moving on from there, you mentioned that restrictions on social contact and the closure of your shops had a significant effect on your fundraising abilities. You also state that UK and Scottish Government funding was critical to your success. And you say that when the funding came, it was bureaucracy-free. How important was that the funding was bureaucracy-free to your ability to help children and families? If you'd had to be dealing with bureaucracy, would that have made a big difference in your response time, the range of services you could offer?
Yes, I mean, it would have made a difference. I wouldn't want to overstate that. CHAS, although we work very closely with the NHS, we're not part of the NHS, and the majority of our funding comes from voluntary donations from the generosity of the public, and often those are funds raised in events which bring people together, so many of them had to stop. And so as an organisation, we were making sure that we could pay our staff every month, and that we were meeting our financial obligations and the policies and covenants around reserves that we have in place, and we would have not been able to continue delivering services in the way that we did and to the extent that we did without the additional government funding that came in to compensate for the lack of fundraising possibility and the ability to use the furlough scheme in respect to some of our staff.
And how important was the timing of that funding? Did it arrive at a good point? Or did it take too long?
Yes, it did. It took too long, and it arrived at the right moment in time. What I would say is that once the money had been provided by the Treasury and that had come through Barnett Consequentials, decisions were made quickly at that point. But both governments should have worked together earlier to recognise that this is hospice care, both children and adults hospice care is a core public service, but it is not funded in the same way as other core public services. It is funded through the generosity of the public, and when the ability to obtain that funding breaks down, as it did during the pandemic, then an alternative provision is required. Otherwise, the service can't continue.
Yeah. So in future, this, in your view, should be something that should be front and centre of the minds, in the minds of those responsible for public health?
I think it's critically important, and I would say critically important with a pandemic situation as well as in a pandemic situation.
Yeah, thank you. You go on to talk about national guidance, and you say that initially national guidance didn't consider the needs of hospice environments generally, and more specifically didn't consider the needs of children. And you had to then adjust the general guidance that was available or interpret that. How easy or difficult was it to interpret and adjust the guidance for use in children's hospices or in the community in a palliative care role?
It was possible, but it did require a lot of thinking, and part of that is that the hospice provides a high degree care for children with a high degree of acuity, a high degree of clinical need, but is also a homely environment. And so we needed to be safe, we needed to keep our staff and children and families safe, but also wanted to try and provide as homely environment as possible. And much of the guidance, I think, was initially written with the perspective of an acute hospital in mind, where the intention is not to provide a homely environment. The focus is on delivery of a clinical service. And so it did require us to read several sets of guidance. So for hospitals, for care homes, for community settings, and say, well, actually, how do we apply this? And ultimately, we used the best judgment that we could to balance the need to deliver a good service with keeping people safe.
Were you able to contact any government departments or teams to highlight the need for hospice-specific guidance, which also took the needs of children into account?
We did raise that, and we later on in the pandemic we identified a contact at Health Protection Scotland who was able to provide excellent and consistent advice, so became a named person that we could contact with queries and questions, and took the time to understand the service, so we didn't need to explain everything lots of times over. They were able to provide very, very effective advice, but it took some time for that to be put into place.
So would you then think that one of the things that we could focus on in the event of a future pandemic would be to ensure these relationships are set up from the outset? Would that relieve a lot of anxiety for people and make the work of third sector organisations more straightforward?
Yes, I think it would, and I think it speaks to a slightly wider point as well, which is to understand and recognise what service, who is providing what service to whom, and that not all public services are provided by the public sector.
Yes.
And actually there are other players, often the voluntary sector, who are critical in providing public services and delivering them, and so understanding the nuances and complexities of that is really important from the outset. And I would say that, again, that is a lesson that is not just applicable to a pandemic situation, but more broadly to how services are planned and delivered across the country.
Thank you. You then go on in paragraph 47 to state that guidance required that children who died at home with COVID on their death certificate be placed in body bags before transfer to your bereavement suite, and that families weren't able to see their children again after they died. Was it parents' choice to have their deceased child transferred to your bereavement suite, or was that mandatory in some situations and beyond parents' control?
No, definitely not mandatory, but it is often a choice, and I would say it was a distressing circumstance. And often when we work with families for a long period of time, often parents and sometimes children themselves have questions about saying, well, where will I be at the end? What will happen when I die? What will happen when my child dies? And knowing in advance where a child might be is hugely important. So a bereavement suite is under normal circumstances, is a cauldron which would allow a child after they'd died to be together with their family, to lie in a bed in a cauldron for a period of time between the child dying and the funeral, and it would allow the family to see the child, to say goodbye to the child and spend time together. It's hugely important in the bereavement that follows and in the coping that becomes necessary. And so it was very difficult in the small number of children who died with COVID on their death certificate, where families were not able to say goodbye in the way that they might have planned or wished. And but certainly there was at least one family who wished nonetheless to come to the Rainbow Room and for their child to be in the place that they had planned for their child to be, even though they couldn't actually see them and couldn't undo the body bag.
Were there any families who, after they'd taken that decision, regretted it and wanted to be with their child's body, and if so, what happened then? Do you think there should be exceptions to allow parents to be with their child at that point?
I think the alternative would be that a child would be taken to a mortuary quickly from home. So I'm not sure if parents would have regretted that. I can't speak to that. But I think what I can say is that some rules can go out the window when a child is dying, and we have to weigh up what is the greater harm caused. And I think that there are certainly parents who would have wished to have had more time with their children at end of life during the pandemic than they had, where their child died from COVID, and would have been willing to take the risks associated with that. But people stuck by the rules, and that put families often in impossible choices and forced them into impossible choices.
Is it fair to say this is a very difficult subject, obviously, Mr. Okasha? But if we're talking about possible advice that could be tendered by this inquiry, much might depend on the circumstances, by which I mean the nature of the disease causing the pandemic, as to how much discretion could ever be granted. Obviously, we're dealing with a disease which actually has a relatively low mortality rate. If, for example, a future pandemic involved a disease with a much higher mortality rate, then it might not be advisable to allow any discretion. Do you accept that as a proposition?
I do. I think that's very fair. This has got to be situational.
Yeah. Thank you.
Thank you. Now, you say that in your statement that children with life-shortening conditions and their families were already going through a terrifying time, and the pandemic brought additional stress and worry. And we've spoken about how CHAS dealt with the volume of guidance, but how did the volume and issues of interpretation of guidance and the rate of change impact children themselves and their families? How did they find it?
I think it was difficult. Many of the families of children with life-shortening conditions live in difficult circumstances. Many, a disproportionate number, live in poverty, and the guidance often that was produced was fairly technical. Many of the families that we support have children with rare diseases where the impact of COVID on that child was would have been unknown. And so I think families did worry a lot about trying to keep their children safe, and we saw that actually, that even before lockdown, many families were choosing to self-isolate well before March 2020, when COVID was in the news. We noticed a number of families who had planned respite stays in a hospice who felt that they didn't want to come because they were staying at home now. And I think that reflects a sense of uncertainty, worry, and the natural desire that parents have to protect their children and to keep them as safe as possible. So I think that was difficult in terms of understanding it. I think there were then some consequences of the guidance and regulations for people that were very difficult for families to work with. There was one example I know of a family who described the impact of lockdown on them being that because they were not able to leave their flat, their son was not able to use the bicycle, the specially adapted bicycle that he had, which helped keep his muscle tone, and as a result of that, lost the muscle tone that he had. So there were impacts on children's physical and emotional development as a result of lockdown that I think were not thought of at the point that lockdown regulations were considered.
Thank you, and I plan to come on to that in more detail as well. Next in your statement, you talk about the difficulties of accessing PPE, COVID-19 tests and vaccines from the outset. Particularly for hospices being outside the NHS system. Do you have views on how those things could be made easier in future? Would it be a case of incorporating hospices into the NHS system, or do you have other thoughts on how that could be improved?
Yes, I think that's really important, and it comes back to the point about recognising that a range of providers provide public services, not just the NHS, important and wonderful though that is. The experience that we had in Chas was that initially it was very difficult to get PPE, and we were not able to order PPE through the normal supply chains that we might have used to order other clinical supplies, because we hadn't ordered to that type of PPE before. That changed once a more national supply chain was introduced through NHS National Services, and that worked very, very well. We were able to order supplies quickly. But what I would say is that initially this only was available to social care providers. Now, with the way the range of our services work in Chas, our at-home services are classified and regulated as a social care provider, and our hospices as an independent healthcare provider. So we were able to obtain PPE for our at-home services, but not our hospice services, which seemed to me to be an ill-thought-out route. Now, that resolved itself, but not quickly enough, and I think that is a learning point for future. With regard to vaccinations, I mean, that was an important point. We were at one point in a position where our staff who work in Robin House in the west of Scotland were able to obtain vaccines alongside NHS staff, but our staff in Rachel House were not. They're based in the east of Scotland, and so clearly there was a lack of consistency across the piece in relation to vaccines. I think testing worked relatively well. There were no real challenges with obtaining testing through NHS routes.
Great, thank you. And similarly, in relation to vaccines for unpaid carers, you mentioned that not all unpaid carers were on the priority list because not all are known to their GPs. How could that be addressed in future? Are you aware of any organisation that does have a full list of all unpaid carers, or does such a thing not currently exist?
Not that I'm aware of. I think this is an area where lots of different voluntary sector organisations can play an important role in helping identify families. It's not something that we could do in Chas alone, but there would be, in combination with other charities, I'm sure the voluntary sector will be able to help statutory services develop a more comprehensive list that could be used in future. And I think clarity about the eligibility criteria and the hierarchy of eligibility for future vaccination programmes would be very important. And I think allied to that, it's got to be part of what we've got to think about is what it is a vaccination programme is trying to achieve, and I think government has to be very clear about what the intents are, and if the intent of the vaccination programme is clear, then the hierarchy follows.
Thank you. Now, at paragraph 78 of your statement, you state that some families reported feelings of decreased worth as the narrative around the virus only seriously affecting those with underlying health conditions took hold. There was a sense for these families that the authorities were more resigned to these deaths. Could you expand on this? Were there other things that contributed to this belief amongst families?
That's a really interesting question, and there may well have been. I mean, I think what I heard from families was that the public messaging, particularly in the early days of the pandemic, was along the lines of, for most people, this will be a mild disease unless you have serious underlying health conditions. And of course, if you don't, then that's a reassuring message. But if you do have serious underlying health conditions, that's an even more worrying message. And I think families felt that they were not always being spoken to or considered, and that there was greater value being placed on those who do not have underlying health conditions than those who do. I realised that the messaging was an attempt to be reassuring, but it didn't always have that effect. You ask what else might lead families to think about that, and I'm speculating, but I do know that there are many families of children with complex needs or with disabilities who see and live in a world that is not always designed for their children, and where the needs of their children are not always understood and taken account of. And I think that is a day-to-day reality that many families live with, and is the backdrop to how a lot of things that they hear will be understood and interpreted.
That's helpful, thank you. Now, I understand that the families CHAS supports received shielding letters at different times. Some didn't receive these letters, and that generally families felt the letters didn't contain enough information for children in high-risk groups. Do you have any thoughts on how that issue could be addressed in the event of a future pandemic? Particularly given that early on not much was known about the virus.
I think that's right, and I mean the shielding list, I suppose, was there to act out of an abundance of caution, because it was introduced relatively early, before the full, before as much about the virus it was known as is now. So, but there were families that we support and who know each other, who were saying, well, I've not had a shielding letter, but you have, and we've got similar conditions that we work with. So there was an inconsistency both in the issue of letters and in the timing of letters. I think one of the challenges with this group of families is that many of the conditions that we see are rare. Some do not have formal diagnoses, and so it's very difficult to know how a shielding list might have been built, but I would certainly be very happy in any future pandemic to try and be a point of contact to help identify families who haven't received a shielding letter but thought they might have, and perhaps if there had been some way of the many organisations who work with vulnerable families across Scotland being able to nominate or identify families who really ought to be considered for shielding, that might have been helpful.
Yes, and on the issue of trying to get shielding letters in time when restrictions started easing, some parents you mentioned were uncomfortable at the thought of going back to work and were anxious, but they didn't have shielding letters, so had concerns about proving this. Was there any avenue open to them to try to get such a letter, whether through their GP or some other organisation?
I think through the GP would have been the likely avenue, but I can't speak to that in detail.
Okay, thank you. Now, you've mentioned today that some families decided to self-isolate early on before national lockdowns, and you've mentioned that in your statement, but you also mentioned that other families felt entirely differently, and they thought that the limited time their children had left, they should be able to see family members and do certain activities. Are you aware of a view among families of a need for more flexibility? And as His Lordship has pointed out, it might be that given the nature of a pandemic, it's not possible for there to be flexibility. But did families have a view that they should have more flexibility than they had, so that if they wanted to see certain family members, that should have been allowed, and if they wanted to isolate for longer, that should have been supported?
Some families definitely did feel that they would have wished to have more flexibility about seeing a wider range of family members in the limited time that they had available, or to make sure that their children had experiences before they died. I can't generalise around that. There's a very individual set of choices that parents will make, and many factors, I'm sure, would have weighed on that at different times. I think that in relation to the choice about shielding for longer or remaining home for longer, I think there's something qualitatively different about that. Than making choices about taking risks. So this is actually about families who the people who know their children best, know what is likely to cause them ill health and harm, and were trying to do everything they could to prevent that. And I think the ability to in many cases, employers were very flexible and understanding of the circumstances of people who were not able to return to work or had to continue working from home. But that wasn't universal, and there were certainly families who were put in impossible positions and making very difficult choices.
Yeah. Do you think that other things could have been done to help those families that you mentioned that wanted to isolate for longer, to help them feel more content and confident about measures being, restrictions being eased, and to feel more confident about going out in society? Or do you think that just their experiences would have always been such that they would never have felt confident anyway?
I'm not sure it's always about confidence. I think it's about recognising that parents are experts in their own children and will have a greater understanding of the likely impact of a respiratory condition on the children that they are caring for. And there were families I know who spoke to me and to Chaz who said, I know that if my child gets this, it will have an impact on them because they have underlying respiratory conditions. So I think it was more than confidence and worry. I think it was the fact that there were parents who were having to choose between going to work and keeping their child safe. And that is not a position that any parent should ever have to be in.
Thank you. Now, you also speak about surgeries being delayed, and you mentioned just earlier about children not being able to make use of specialist equipment because of the restrictions. Could you tell us some more about the physical and emotional consequences of delayed surgeries and not being able to use equipment on children that you support, and how that compares to otherwise generally fit and healthy children?
I think that the impact of delayed healthcare can be felt immediately, can be felt in the medium term, and can be felt emotionally, and all those things played out. children did receive healthcare during the pandemic, and there were children who needed to be in hospital who were in hospital. So it is important to recognise that this probably applies to, I suppose, what we might call the second order of things, so things that are not urgent, and but things that are still necessary and desirable to support children. I think the impacts that were greater than delayed access to healthcare were the difficulties for children who were at home for extended periods of time in small flats, in large families, who are not able to get outdoors, and for whom their physical and emotional development was absolutely impacted. I spoke to a mum recently, actually, who described and said that people have to understand that even after lockdown ended, it took me a year to be able to leave my house. And she said that was because my daughter had become accustomed to being in the house and was frightened herself of leaving. So the impact on the mental health of children, it was very significant as a result of lockdown.
Thank you. I want to move on to home learning once the schools were closed. Now, some of the families that you support, as well as having a child with a life-limiting condition, will have other children as well. How did the families with one child and also those with multiple children, how did they cope with homeschooling during periods of closure?
I think generally with some difficulty. There were families who were homeschooling who were trying to be a parent and a carer for their child 24/7, and being a people assistant for their child, and trying to work from home. And doing those four things is not easy, and doing it continuously is really hard. And the impact on parents was very, very significant. And I think it comes to what I would say is the overwhelming impact of having a child with very complex needs who requires care 24 hours a day. It is non-stop, it is exhausting, it is continuously demanding. And if you are in particular a single parent, there is often, during the pandemic and during lockdown, there was often no help available, literally nothing. And so that was hugely wearing for families. I think for families where there are more than one child, very often siblings become de facto carers for their ill child, and their own experience of growing up is impacted and was impacted during the pandemic.
Thank you. Were schools able to provide any sort of assistance for those families, when they were teaching virtually? Or
I think the situation varied from different places. I've certainly heard from parents who say that individual teachers went out of their way to support and help them, to provide materials for them to use at home, but that the system didn't always understand the needs of their parents. And I suppose, often where a child was at home and not in a hub school, or not returning to school after the schools reopened because the family was protecting that child, or the school couldn't meet the needs of that child because they had particular needs, there would have been if that child had been at school, there would have been a range of supports available in terms of pupil support assistance, which were not available if that child was at home, not able to go to a hub school, or not able to return after schooling. And I think some parents have noted and said to me that even in those circumstances, the funding continued for the support to be available at the school. Yes. That funding was in place, but it wasn't delivered in the child's home. And I think there are some examples of where pupil support was provided in a cluster, where there was a small group of families who were supported by a pupil support assistant within the school, but that wasn't generally provided at home, if at all.
Okay, thank you. And following on from that, there's one aspect, the support provided in classrooms by assistants, but also children might have input from allied health professionals like speech and language and physiotherapy to just be able to carry out basic functions. How did the withdrawal or closure of those services impact children's ability to access education? You know, was there regressions in speech, in the ability to sit upright, to pay attention? You know, how did those withdrawals of service impact?
I'm not sure I can speak to the detail of that, but certainly it is the case that families talked about community physiotherapy being harder to access during the pandemic and at times not possible. We have a small number of physiotherapists in Chas who were supporting and supported as many families as they could, but certainly that I think that was a missed service, and I think the same would be the case in speech and language therapy, but I'm not sure I'm qualified to comment specifically on the physical impacts around that.
Sure, thank you. Do you have any thoughts on how support for families could be improved in future in respect of homeschooling?
I think understanding that even when schools reopened and when hub schools were in place, they were not physically suitable for all children. So there were some children, for example, who have respiratory problems where there are aerosol generating procedures that might require them to be in their own room for that procedure to take place, with staff wearing full PPE, which wasn't provided. There were differences between the PPE arrangements for staff who were delivering healthcare to a child and staff who are working in a school with a child, and so the physicality of the buildings was not always suitable for children. I think underlying that is something that I've heard from parents, which is that there was a tension between the medical advice they were receiving, which was be cautious, and the educational advice they were receiving, which was schools are open again, why don't you come back? And parents were confused sometimes. Which advice do they follow? Medical advice, educational advice, and I spoke to a mum last week who said that during the pandemic she had to make choices to be unsupportive to my daughter's education in order to keep her safe.
Yes. And in fact, you say in your statement that parents felt the needs of their children with life-shortening conditions were not considered by the government when planning the return to classrooms. To what extent was the general guidance that was provided useful to those families, if at all?
I think that was the view of many families. I can't speak for all, of course. I think some examples of where the guidance was not always meeting the needs of those families would be in relation to children who were not returning to school, perhaps because they had required aerosol generating procedures that couldn't be provided in school, but their siblings were. So their siblings were going to school, being exposed to other children and potentially to transmission of the virus, and then they were coming home. So there were parents who were making decisions, and some parents who I think made decisions for their siblings not to go back to school when the siblings could have gone to school because of the impact on the ill child at home, and that I think was not fully teased through. So had, for example, there been a different approach or a more bespoke approach put in place where required around PPE within schools for those who were in contact with children who were vulnerable, either ill children or siblings, I think more children would have been able to access education more quickly.
And were you able to, you mentioned that you established connections with a certain government department. Were you able to utilise those relationships to highlight these issues and concerns?
We certainly sought to and had a very open relationship with civil servants and with ministers. They were, in my experience, very willing to listen and to respond and to involve the right civil servants in government. There were times when we offered advice and thoughts that or offered advice and that advice wasn't sought or taken up. But in the main, I found the civil service to be responsive during that period.
Great. And do you know, were the siblings of seriously ill children given places in hub schools? Or is your view that they should have been if they weren't?
I can't speak to that. I don't know.
No problem. Thank you. Yes. In paragraph 124, now we've spoken about how the guidance was general, but in 124, you commented that guidance for children with additional needs was too broad and did not always consider children's complex health needs and so on. Is this a reference to specific guidance, or is it a reference to the general guidance not being appropriate enough?
I think this is speaking to guidance around schools and the kind of things we've talked about and how siblings and might be accommodated. I think what was that often the we have rare and unusual medical conditions, and there is not easy access to advice for schools about how to support those children and their rights and wishes. And I think that those circumstances where parents were really listened to and involved in planning the best outcomes for families.
Yes. And, you say that parents felt that national guidance what was wrong, and that had there been national guidance, it must local authorities to be more aware for risk assessments and to actually carry out risk assessments and create individual plans. Are you aware of families or as it's contact local authorities to have on lack of requirements?
I'm not sure if that it's not something that families have spoken to me about, but I would imagine that yes, parents are very powerful for their children often.
Yes, and on that basis, I take it you wouldn't be able to comment on the uniformity of families' experiences across the country in putting those things in place?
I think only to say that often I will have heard from families, and families will have come to CHAS where things haven't worked well, and there will be many examples, I am sure, of where things have worked well, and but often the things that I tend to hear about are those where families have had more difficult experiences.
Thank you. Now, you at paragraph 115, you say that parents were anxious to emphasise the right of their child to an education as enshrined in the United Nations Convention on the Rights of the Child, and their right to reach their full potential safely as enshrined in GIRFEC. They didn't want their child to miss out on education time, but they felt they had no choice but to keep them off school. Why was it that they felt they had no choice? You've spoken a bit about it already, but
I think the parents I've spoken to had genuine and real and credible fears that if their child contracted COVID, that it would have a devastating impact on their health. And that was particularly the case with children who have respiratory or underlying respiratory challenges or difficulties. And so parents were choosing as to whether they should keep their child at home and safe or go to school and educated. And I have certainly spoken to parents who made the decision to keep their child safe at the expense of their child's education, but felt that that was the lesser of two evils. That I think is a real problem that will impact on those children for the rest of their lives, and in the case of siblings, perhaps for longer again.
And you've touched on aerosol, some children requiring aerosol generating procedures. You also mention that some children are ventilated and need a separate room, and that was one of the issues in children returning to school, the lack of that. Were those spaces available prior to the pandemic?
Well, I can't speak to every school. I suppose prior to the pandemic, then there would have been no need for a separate space. Those children, if a child requires suction, well, that could have happened in a room with other people. It was really only because of the guidance around the risk of the formulation of droplets from those procedures and the contracting of COVID from that it became an issue. So it may well be that there will have been some schools that physically could not have accommodated that, but I imagine there are some that could.
Good, yeah. So, I mean, with children that do have respiratory conditions, often, or my understanding is that often, even during flu season, they are more significantly impacted and will be hospitalised, admitted to hospital as a result of contracting a flu that perhaps their sibling contracted and was perfectly fine continuing. So even in those, given that, even at those times, they wouldn't have had a separate room for these children to have these procedures carried out.
That's not my understanding. Okay. That is my understanding, that wouldn't have necessarily been the case. In the same way, in our hospices where there are children who are ventilated or require suction, that can be done. That doesn't require a special space necessarily to happen. The differentiating factor in relation to COVID was the increased risk of contracting COVID as a result of aerosol particles being generated and being in the air. So that wouldn't necessarily have, that I think the issue was COVID specific during that.
I think it's in your statement, or perhaps we've heard from someone else, that some schools had other rooms for children with behavioural issues and additional needs there, and they used those additional rooms to isolate, to provide a calm environment for those children. Do you think more use should have been made of those rooms for children that required aerosol generating procedures?
Well, it certainly sounds sensible. I mean, I think the key point in this is that for children with exceptional healthcare needs, and that's what these children have, exceptional circumstances need to be made. And by that I mean schools need to work with families to understand the art of the possible and to do anything that supports children to be safe and able to access their education. And I think there was variation across the country in the degree to which that happened.
Yeah.
Yes, Rami, you've got 15 minutes.
Thank you, my lord. And with that, if it is, do you think that issues of prioritisation come into play here, that behavioural needs were in some cases perhaps being put ahead of essential physical health needs? And do you think, if that's the case, do you think that where guidance stipulates that a separate room is needed for an aerosol generating procedure or ventilation, that the guidance should place an obligation on schools or other education providers to provide such a setting? For example, adding a portable cabin on campus, or in some other way setting up that space?
I think that would be very reasonable. We're talking about a very small number of children with life-shortening conditions who require aerosol generating procedures. I think that adaptations and physical adaptations to schools are obviously dependent on the school that's there. But I think, stepping back, a more broader point is that we should expect children who have life-shortening conditions to be able to play a full part in society, to receive an education, and that is important in its own right. But it is also important because the rate of medical advance means that many children are living much longer and will live into early adulthood. These are children who are entitled to an education. They didn't receive it during COVID, and they should have.
Yes. And presumably the impact for those children of missing that part of their education is more profound than on children that are otherwise fit and healthy. Does it, in your experience, have more of an ongoing effect, or is it limited to the gap in education?
I think it is a question for an educationalist. I would imagine that missing education for any child will have an impact on their development. I think what is important and what was specific to the children that we work with in Chaz is the intensity of care needs that those children have, and the fact that if you live in a very small house or flat and are there the whole time educating and caring for your child, it is hugely physically demanding on the parent. And I suspect that that is not the circumstances which will lead to the best educational outcomes for children.
Thank you. And did you have any feedback from parents about the willingness of schools and local authorities, Scottish Government, to meet the extra needs of their children?
I certainly heard parents praise teachers for producing materials, for adapting materials, providing lesson plans for parents to deliver, but I also heard parents saying, but I struggle to do that because I'm also trying to look after other children. I'm also trying to work from home, and I'm a single parent. I can't do all this.
Yes, thank you. Now, is there anything that we haven't spoken about today that you would like to address?
I think the thing that I would want to say is that although the number of children with life-shortening conditions is small, it is hugely important to think of the impact on them of decisions. There are, where a child has a short life, they and their parents try to squeeze it all in, and for many of us, COVID was a really tough time, and we lost time together with our families and loved ones. When time is also short for a family, it has a concentrating effect, and the impact of regulations and lockdowns, whilst very understandable, has an impact on this group of families that was not always considered or thought through. And so that may have been for very understandable reasons, because we were, as a society, learning so much in such a short space of time. But I think the learning from this pandemic is that the implications for these families need to be considered to make sure that the health, emotional and educational impact is minimised, and that families are supported as much as possible. And I think there are many families who felt that they were not supported as much as they ought to have been.
Thank you very much.
Yes, thank you very much indeed, Mr. Okasha. Very good. You've got one more witness, Ms. Rami. We'll come back. We're a little bit early, if we can, between about 10 to 5 to 3.
Thank you, my lord.
Now, good afternoon again, Ms. Rami.
Good afternoon, my lord. My lord, we now have Helen Malo of Hospice UK.
Thank you very much indeed. Good afternoon, Ms. Malo.
Good afternoon.
Ms. Rami, when you're ready.
Thank you, my lord. Good afternoon, Ms. Malo. Please could you tell us a bit about your own background and the background of Hospice UK?
Of course. So I'm Helen Malo. I'm the Senior Policy and Public Affairs Manager for Hospice UK in Scotland. So Hospice UK is the national charity for hospice and end-of-life care. We're a membership organisation, so all charitable hospices in Scotland are part of our membership. And my role in Scotland, certainly at the start of the pandemic, I was the only Scottish-based member of staff for Hospice UK. And my role is really about working very closely with all Scottish hospices, supporting them to have a national voice for the sector, supporting them to try and prioritise palliative care and hospice care in Scotland at a national policy level.
Thank you. And can you tell us a bit about the work that Hospice UK does? I understand there are 16 charitable hospices across Scotland that are members of Hospice UK, and they support 22,000 people a year, both providing palliative and end-of-life care. Can you tell us a bit more about that, and also speak about, we've heard in terms of children what this difference means, but in terms of adult care, the difference between palliative care and end-of-life care?
Yeah, so maybe if I start with that and then talk a little bit more about hospice care specifically. So palliative care is care for patients when with an illness when a cure is no longer possible. And we, at Hospice UK, we often refer to the World Health Organization definition of palliative care, and that, I can read it out, but that's about having an approach which improves the quality of life of patients and their families facing the problems associated with life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. So it's really about having holistic care of a patient, having a team approach to supporting their needs. So it might be around pain relief or relief of other physical symptoms like breathlessness, but equally it might be around psychosocial support or spiritual care, and it's really embedded. It's about the needs of not just the individual but their family and their loved ones, and it's really about affirming life and supporting people to live their best life as fully as possible. And then end-of-life care is part of palliative care. It can be commonly understood as care in the last year of life, but equally it's quite context dependent, and other people might refer to it in terms of when someone is recognisably in the process of dying, and that might be in the last months and weeks and days of life. And then more specifically about hospice care, so that's hospice care is a really vital, important provider of palliative and end-of-life care, and in Scotland they provide support, direct to patients, but also to their families and loved ones. And I think people are very familiar with, sort of in their local communities, their local hospice. They're sort of very well-known institutions, but perhaps they're not always aware of all the care that they provide. So hospices will provide inpatient care, but actually the majority of the care that they provide across Scotland is out in the community. So most hospices will have community teams where they'll visit people at home, they'll provide outpatient appointments, a lot more now some virtually as well, and sort of day therapy services. And there's sort of other services as well that they don't all provide the same services, but there's a wide range of support for patients and their families, like respite services, bereavement, counselling, sort of compassionate community type initiatives like befriending services out in the communities. They might do drop-in information services or welfare support. So it's really, again, it's that holistic care of the individual and their families. But hospices are, so they're charities, so our members are the charitable hospices, and so they're not part of the NHS, but they're really important partners in the wider health and social care system. So as well as providing direct care, they'll also provide clinical expertise and support to other members of health and care staff, so to GPs, district nurses, to colleagues in hospitals, so providing that expertise and palliative care advice. They'll provide strategic leadership locally around palliative care. They provide education and training, and they really support the NHS and statutory services, so they'll help patients to stay at home and to avoid unnecessary admissions to hospitals. So they are a really vital part of the wider health and care landscape in Scotland.
Thank you. And you state at the in the penultimate paragraph of page 1 that not every health board in Scotland has a charitable hospice, and the NHS and other partners provide specialist palliative care in areas, geographical areas, where there isn't a hospice. Now, typically, third sector organisations complement NHS services or meet a need where the NHS can't. But it seems that in the case of hospices, it's the other way around. The third sector meets this need, and where it can't, where it isn't possible, then the NHS steps in. Is that correct?
I mean, the hospice sector it's a unique sector, so it does provide an essential core service. Palliative care is an essential service to provide to people in Scotland. And there is a mixture of how that is delivered across Scotland, so both charitable hospices and then also NHS services, as you say. And I think that's partly reflected in just the hospice movement and how that's evolved historically over time. And I mean, if you looked at a map of Scotland and where the hospices are, the majority of hospices are around the central belt, and then you do have a few other hospices scattered across Scotland. Yes. But they very much evolved based on community need and sort of the drive and energy and determination of local communities to raise the funds and have a hospice in their local community. So it is a unique sector. There isn't another part of the health service where so much of a core service is provided by the voluntary sector. But it does mean there's, you live in one part of Scotland, you might have a local charitable hospice, you live down the road in a different area, and your needs might be met by the NHS.
And given that setup and how integral it is, and and where there is a charitable hospice, there not being the NHS provision as well, does that make funding even more vital than for other third sector organisations?
Yeah, absolutely. So for charitable hospices, on average, just over a third of their funding comes from statutory sources, and then nearly 2/3 has to be fundraised by their local community. So through charitable donations, through shops, through people running marathons and doing all the support that people will be have heard of. And then the impact during the pandemic with the restrictions that were brought in, that overnight that essential funding stream, a large part of it just stopped. So with shops having to close, with not being able to have big events and fundraising events, then that had a catastrophic impact on the sector, because their services were still of vital importance.
Yeah.
People were still dying of all the, cancer and heart failure and all the other reasons that people in Scotland are dying. Their care was still absolutely needed,
Yes.
but their funding revenues had been dramatically cut because of the restrictions.
So how were they able to continue their services? How were they able to compensate for that?
We were very thankful that Scottish Government did provide emergency funding for the hospice sector. So
Yes.
Hospice UK and Hospice in Scotland worked together to ensure that there was a commitment from Scottish Government. So it related to Hospice UK in England at Westminster level, secured a commitment for emergency funding for hospices, and then there was consequential funding which came through to Scotland, and then Scottish Government thankfully did commit to passing that on to hospices. And without that, hospices would have had to cut services, or they wouldn't have been able to continue. So we're very thankful that provided some short-term stability for the sector.
Yeah.
The impact and broader challenges around funding and the sustainability of the sector are ongoing. So there are certainly issues around the funding of the hospice sector, which need to be looked at the long term. But during the pandemic, we were grateful for the support from Scottish Government.
Thank you. Now, we've heard from a number of organisations and individuals who stated that they found it difficult to keep up with the volume of guidance, the frequency with which it was issued, and to fully understand the intended meaning. And we've heard from CHAS to some extent on this, but in the case of hospices, there was an additional difficulty because the guidance, at least initially, didn't refer to hospices. Did there come a point where the guidance did start including hospices? And if so, when was that?
Yeah, and I think, that question and the points that you and others have raised about the volume of guidance absolutely was reflected in the hospice sector. That was certainly when I was talking to hospice staff, that was one of the biggest challenges for them to deal with, was just the sheer amount of guidance coming out and how rapidly it changed. And then as you say and point out, the additional challenge is that it's not clear where hospices fit, and for a long time, hospices weren't necessarily specifically mentioned in the guidance, and it's quite hard to specifically pin down when exactly, because there's so many different strands of guidance around visiting and testing and who's the key worker and vaccinations and infection control. But I think it was towards the end of 2020 and then sort of into 2021 where there started to be a bit more clarification around, specifically mentioning hospices, or that this, perhaps not in the guidance, but having confirmation in follow-up from Scottish Government that this does also apply to hospices. But then there was an additional challenge where sometimes guidance would mention hospices, but that the unique context that hospices work in wasn't fully understood. So there might be examples where guidance around infection control would put hospices in with sort of social care providers, but actually a lot of what hospices do, and maybe their inpatient units, are more akin to an acute hospital setting. So there was, I guess, an issue with hospices not being mentioned in the guidance, and then even when they were, a lack of understanding of the context that they were working in, which was very challenging for staff.
Yes, thank you. And until the point where they did start being mentioned, how did your adult member hospices go about the task of translating the guidance for hospices, and what was the impact of that additional work requirement on them?
speaking to hospice staff, it was a massive job. And I know in some hospices, someone was telling me that they had one of their consultants couldn't do face-to-face clinical work because they needed to be shielding. So in essence, it was their full-time job to go through guidance, and it could come out, multiple times a week. The guidance would change, so they would have to sit down and go through it and then try and translate it and think through how does that apply to hospices and our specific context. I think hospices spoke very positively around their local links with public health staff, like with an infection control sort of advice within their local health boards areas. But they're very much reliant on their local relationships that they have with public health teams. It wasn't that there was a specific, clear structure or mechanism for them to get that advice. And I know some of them had said, several months into the pandemic, they managed to get a named contact within Public Health Scotland, and then that would be their go-to person. And just having that link was really helpful. But up until that point, it was really challenging. And then the impact for them was just the sense of uncertainty and are they doing the right thing, and confusion, and feeling, people said, they felt like hospices were several steps behind, that they were constantly on the back foot. So it was a huge stress on staff, and I think it just goes back to perhaps the wider system not having that understanding of the unique contexts that hospices work in.
Thank you. Now, you go on to set out in the first paragraph of page 2 that Hospice UK was involved in clinical leadership, the development of national guidelines, local protocols, in local and national planning, and contributing to the research community's rapid response to the pandemic. Could you tell us, please, a bit about the ways in which Hospice UK contributed to that?
Yeah, I can. I mean, I think my briefing actually says hospices as opposed to Hospice UK, but I'll talk about both if that's helpful. So Hospice UK, certainly, I really saw us as an organisation coming into our own around that support and clinical leadership. I think we had a really important role because we work across the UK in terms of bringing hospice staff together. So we had a weekly, we called it a clinical echo. It's like an online, like a webinar or like online educational thing where 300 hospice staff from across the UK would join each week, where we would share sort of emerging guidance and national learning, and have that safe space where the sector could come together and talk about the challenges that they were facing and what's happening across the UK. We also, clinical colleagues of mine set up, I think it was fortnightly clinical meeting with nurse leads from across the 4 nations to share sort of learning and how practice was changing across, changes to visiting guidance or infection control and communication and education and how it impacts hospices. Certainly in England, Hospice UK was involved in national guidance. We didn't in Scotland in the same way, but hospices in Scotland were very involved in, so they fed into national guidance, so they provided, because they are experts in palliative and end-of-life care, they fed in and provided clinical leadership around some of the national guidelines, so around symptom control, around alternatives to standard palliative care drugs, around some of the visiting restrictions. And then locally also, hospice staff would feed into local guidelines. So I know staff, the Edinburgh hospices fed into guidelines, sort of COVID guidelines across the Pan Lothian region. So yeah, I think their clinical expertise and leadership was very helpful at both a national and local level.
Yeah, thank you. And further on in paragraph 2, You speak about, I understand that hospices are regulated by Health Improvement Scotland, and you say that some hospices felt burdened by Health Improvement Scotland while others found the ground team helpful. Could you expand on that? What was it that worked and what was it that didn't work well, and how could that be improved in future?
I think so. From conversations I had with hospice staff about Healthcare Improvement Scotland, there was, like in all the things that we'll probably cover today, there was variation across Scotland, so people's experiences and different hospices' experiences differed. I would say the general feeling towards his from hospices was more negative than perhaps some of the other bodies, so they felt that perhaps his was a bit late to act or a bit unsure of their role and how that fitted in with other agencies in Scotland. I mean, some of the practical examples that hospice staff gave was around every time there were changes to the infection control manual, his wanted them to update all their standard operating procedures across the hospice, and that could be sort of 14 separate documents, and then a couple of days later it would, things would change, and then they would have to go back, and so it was around some of like the burden of what they were expected to do, and I think hospices or some hospice staff felt they could take a bit more of a pragmatic approach, but equally I heard positive stories as well around his, and perhaps at an individual level, so individual staff in his being helpful and sort of being on the end of the phone if they needed them. And certainly one hospice who I think was inspected by his quite early on during a pandemic, they felt that his was understanding of the situation and didn't want to place too much burden on hospice staff. So I think it was a mixed picture across different parts of his, but also across different hospices.
Thank you. And in the next paragraph, you mentioned the Scottish Government Palliative Care Policy Team and being able to contact them to have advice and communication from them. Was advice and guidance available from that team from the outset, or did it come later on?
I would say from the outset, I think. So civil servants and the palliative care policy team were very helpful, so they were available if hospices or Hospice UK had queries. They would try and, so it wasn't so much that they were issuing guidance, it's more we could go to them to ask for clarification. So some of those things that we were talking about around the guidance not being clear, we could approach their team and they would try and find out the answer or be helpful. Or, I mean, later on in the pandemic, they were helpful in terms of connecting hospices with the National Clinical Director, Jason Leach, for a query around visiting guidelines, for example. So, I mean, hospice staff have certainly spoken warmly of the support that they got from civil servants.
Thank you. Now, on page 3, you state that more people were being cared for in the community. Am I correct in understanding that adult hospices had to reduce the number of beds that were available within hospice buildings?
So, it varied from hospice to hospice. So some did reduce beds. This might be because they were trying to move to all single rooms, so trying to reconfigure things within the hospice building to facilitate visiting or to help with infection prevention and control. Some others also shifted their capacity, so they saw that there was greater needs in community settings, so they closed beds or moved staff so that they had greater support and capacity in the community settings.
And were staff who worked within the hospice buildings kept separate from those who worked in the community, or could it vary from shift to shift where an individual member of staff was working?
I mean, I don't know the specifics, so it would probably vary from hospice to hospice. Anecdotally, I know that they talked about having separate teams or two teams for different aspects and not wanting to mix them together. And also I know of one hospice where within the hospice building, the clinical, sort of the inpatient bit of it was kept separate from maybe more of the admin support or the non-clinical sections. So they were certainly following the guidance at the time, but trying to adapt it and work it for their own individual context.
Thank you. And do you have an idea of how long staff would spend in patients' homes? Was it, less than an hour? Would it be half a day, a full day, overnights?
I don't have specific timings or things like that. What I did hear from staff was that their visits into people's homes were taking longer than they did prior to the pandemic. So this might be, some of the reasons for that, some of the just practical reasons, like having to put on all the PPE before going in. And in some areas, staff had said that before COVID, before the pandemic, other healthcare providers might have been doing more of the tasks, but actually if some other healthcare professionals weren't going, or social care professionals weren't going in to do some aspects of the work that they would have done prior to COVID, that meant there was more for hospice staff to do.
Are you aware of how they approached infection control within people's homes, within the community settings?
They followed the guidance at the time, so I don't know if I can talk you through the specifics of that, but certainly wearing the PPE, following the social distancing, minimising contact, supporting families as well. There was guidance for community settings at the time, so I suppose they would have been looking at the specific guidance around infection prevention and control.
They didn't develop their own practices, they largely followed the national guidance. Is that correct?
They would have followed the national guidance, but then again, it's the sort of translating it into the hospice context and working out your own procedures to follow within that. But because their hospices are independent charities, so they'll all, have their own approaches to do, and I don't have that level of detail.
Sure, thank you. Did the member hospices feed back to you their perception, either objective numbers that they maybe derived somehow, or their subjective perception of how successful their infection control measures were, and if whether keeping the two workforces where that was the case separate, whether that prevented outbreaks within a hospice?
We don't, so Hospice UK doesn't have data on that. I think my impression from talking to people was that infection control was very well managed, and it's something that hospice staff have experience in. So yes, there were additional measures being brought in by COVID, but they have, the care that hospices provide is generally very good, excellent care. They're regularly inspected. Anyway, they're quite used to following these procedures and protocols. They have good links in with local infection control teams and public health teams. There were some examples of outbreaks, but I think anecdotally these were small, these were well managed. Certainly it wasn't perhaps what you saw in some other settings or care home settings, for example. That wasn't the case in hospices.
And for the staff, what was the impact of going round the different houses? And I think some made visits to care homes as well. What was the impact of that on the staff members?
I can talk, I think I heard a lot from hospice staff who, so perhaps from their community teams who were going out to visit people at home. I think certainly at the start of the pandemic, they felt a lot of pressure and a burden of responsibility. I remember like a community team leader saying she was haunted by the memories that she has of that period where she was asking her team, her colleagues, to go into people's homes. This was before vaccinations, it was before the full understanding of the risks of COVID. I think hospice staff have such a strong wanting to do right by the patients and families that they support. So they were seeing that in some areas other staff weren't going in. So certainly sometimes hospice staff said that they were the only people sometimes going into someone's homes. They could be described as a lifeline for patients and families. But they felt that burden of responsibility, that weight of responsibility, that conflict between wanting to continue to support patients and families, but worried about their colleagues and the risks that they were taking, and worried about the risks to their own families and how to keep them safe. So I think there was probably a lot of conflicted feelings and stress that they felt. I think as well, in the very beginning, that it was unclear in terms of the guidance about who could go into people's homes and sort of the caring role and who was covered by that. So they didn't want to do the wrong thing as well. So there was that pressure that they felt.
And given the increase in patients being at home, was that viewed positively? Did patients and families prefer to be at home, or would they have rather been in the hospice setting?
I think so. I can't speak on behalf of patients and families, but I can share what hospice staff have said to me and about the impact on patients and families. Certainly, I think typically hospices saw less inpatients and more people in the community. Staff did talk about families being worried about not wanting to go into an inpatient unit, be it a hospital or a hospice. I think they were worried about the not being able to have the support from family members, so visiting being restricted, and a bit of fear about going into an inpatient setting. So I think you're asking, was it seen positive, like the shift in terms of people being treated at home? And I think, so even prior to the pandemic, there is a demographic shift in terms of where people are being cared for and are dying in Scotland. So more people are dying at home, and then COVID hit, and that rapidly accelerated a shift that we're already seeing. And I think a key thing for me is that we don't know what people's experiences of being cared for and dying at home during the pandemic have been like. And I mean, one of the things I would hope this inquiry, perhaps, you're hearing directly from families, that you get a sense of that, because so many more people were dying at home, but there wasn't more capacity. There weren't more staff necessarily supporting them, and in some areas we know social care staff either weren't going into people's homes, or perhaps people were scared to let carers come in to support them. So there was this shift, but we don't know what people's experiences were. And even though we know at a general level that a lot of people do say they would prefer to be cared for and die at home, but that comes with the caveat that, you know, the support needs to be there, the staff needs to be there, the resource needs to be there. And certainly from a hospice perspective, they're a key provider of that care, but they need to be supported to be sustainable and well resourced. So it's a complex area, and I think I would hope that there would be learning from the pandemic about people's experiences in the community, not least because that demographic shift is continuing. The need for palliative care is growing in Scotland, so there will be more people who need palliative care, and there will be more people in the community who need palliative care. So how can we meet that need in the best way? How can we resource and prioritise palliative care and all the sectors who deliver palliative care, including hospices?
I want to move on to the virtual support that hospices were able to provide. You mentioned that some had to invest in the IT infrastructure. How easily were they able to meet that cost, and how quickly could they put the infrastructure in place? And once that was done, were all patients able to interact through the online services?
I think it was a mixed picture, again, like many things. So I know of one hospice who said they definitely needed to invest in their IT infrastructure. They needed to install a fibre optic cable up the hill to reach the hospice, because they said prior to that they could only do 2 Zoom calls at a time. Like the infrastructure just wasn't there. And this is where overnight a lot of services shifted to providing more virtual support. So where hospices felt they couldn't deliver face-to-face care and support safely, many, if not all, shifted to providing that more virtual support. But they didn't, as you were saying, didn't necessarily have the infrastructure or the equipment to support that. So I know, some hospices would pay for that out of their own funds, out of their reserves. I know some hospices did get some grant money to pay for, I don't know if it was iPads or other tablets to support some of the virtual consultations. So it was challenging, and I think some of that, the technology was unreliable. And I think there have been positives and negatives of moving to more of a virtual model during COVID. And I think on the positive sides, it meant hospices could continue the support to patients that they otherwise could not provide. So it was really important for them to carry on supporting patients and families. And some even said that they were reaching more patients than perhaps they would have done in the past. So people who perhaps wouldn't have been able to come to the hospice in the past because they were too unwell to travel, now, since they shifted to more of a virtual model, they could provide support to them. So there were definite positives, but on the other hand, there were negatives in terms of some patients and families found it hard to sort of use a virtual model. They might not have had access to a smartphone or a tablet to do that. I think some staff really struggled with the shift to virtual. I mean, palliative care, it's a very hands-on, it's very tactile. You know, palliative care nurses are hugely warm and they like to hug people, and it was a difficult shift sometimes to maintain the essence and ethos of hospice care digitally. And though it did help them continue to support patients and families, it also, we talk about digital exclusion, it can exacerbate existing inequalities if people don't have access to the technology or find it hard to use.
You go on page 3 to state that hospices were able to recruit and train additional volunteers to provide bereavement support. What was the background of those volunteers, and did they visit people in their own homes, or did they provide support virtually?
I mean, on that specific example, I'm not sure what the backgrounds of the volunteers were. I would have to ask the individual hospice. But we did see hospices reaching out and recruiting volunteers to provide bereavement support, to provide delivering shopping to families, or support with meals. And I think one of the strengths of hospices is how well loved and regarded they are within their community, and how embedded they are within the community. And I think some of the learning perhaps from the pandemic is how quickly hospices were able to mobilise that community response, and how volunteers and hospices really stepped up during the pandemic. So I think that's perhaps a positive and a sort of testament to hospices and how well they are part of their local communities. I mean, in terms of volunteers, it sort of varied. But so, I mean, volunteers in hospice shops obviously would have had to stand down, or volunteers around, fundraising events and things like that. And I think some had less, wanting to protect their volunteers and not perhaps wanting them to come into the hospice or having lots of direct face-to-face contact. But they did have a wide variety of roles, and they're a crucial part of the hospice sector. So without them, you wouldn't be able to deliver the care that hospices do.
Yes. And that there seems to be a difference there between the recruitment of volunteers and the recruitment of paid staff, because later on at page 6, you mentioned that the recruitment and retention of paid staff was an issue for some hospices. Are you aware of the reason for that difference?
I think with paid staff, so it was an enormously challenging environment that they were having to work in, and it's an environment that had very quickly changed. So I remember hearing from nurses in inpatient units in hospices just describing how quickly that changed. Inpatient units are busy, bustling places normally, and you walk into a hospice that's very warm and welcoming, and it very quickly changed. So people being in single rooms and having to restrict who was coming in, and staff having to wear all the PPE, and also with all the testing and staff going off sick or staff having to isolate, staffing was a challenge, and difficult to maintain staffing levels, and with some staff being on furlough as well. So that all puts an extra pressure on the staff who remain. So it was very challenging for staff to do that. And in some areas, yes, hospices said they had issues around recruitment and retention.
So perhaps the pressures on volunteers were less than the pressures on paid staff, and that had an effect on retention, particularly. And
they're doing different roles as well. So, yeah, I think they're two different things.
Thank you. You state that hospices needed to put some people on furlough to save money, but it also created discord within teams between staff who were still at work and those who were furloughed. would it have been more beneficial to have a rule for hospices that would have allowed furlough funds to be used to keep staff working?
I don't think so. As Hospice UK, I don't think we have a specific view on that. And I think the majority of staff, hospice staff who were furloughed, it was either roles like retail managers or people who organise fundraising events, so roles that, practically speaking, weren't happening. But then it was also staff who perhaps were more vulnerable or at risk or shielding, who were furloughed. So I think it would have been probably hard to do that, but I think there was definitely an impact on staff and the workforce and morale around the introduction of furlough, and that was quite hard for the staff themselves and also managers to manage that situation.
And you speak in your statement in relation to PPE about how some NHS boards initially didn't deem hospices an initial service, so didn't assist or prioritise them in respect of PPE. And this was despite the fact that the health board itself wouldn't have had palliative services in that area. What was the impact of that on patient care?
So, yeah, I mean, PPE, that is certainly an area where, again, it varied markedly across different hospices and different parts of Scotland. But as you say, hospices are providing an essential service, but because they're not within existing NHS structures, then it does vary in terms of, for some of them, they're just outside those standard supply chains. It does vary, so some are more embedded in the existing structures and they had an easier time accessing PPE, but others, so the one that you mentioned, that was an example of one hospice where, their local health boards they found it very hard to engage and be part of that supply chain. But they said as soon as, I mean, it took some time, but eventually the health boards had deemed them an essential service. I think that was just local terminology. But when that had happened, then they were suddenly, doors were opened and they found it a lot easier to access PPE. But I did, so certainly for some hospices in some parts of Scotland, it was enormously difficult having the supplies of PPE that they needed to provide essential care to patients and their families. Yes. They were having to have daily huddles trying to work out where they could get access to PPE that they needed to continue to see patients. So and for some it took months until they got a reliable supply chain for PPE.
Did it impact clinicians' ability to have direct contact with patients?
I heard from one hospice who said yes, they essentially did have to ration like the available PPE that they had, so they had to think about what patients could come into the hospice or which staff could go out and see patients. So it did, in that way, yes, it did impact clinical decisions and the care that they could provide.
Do you think, in terms of lessons to be learned for the future, that it's important that the essential service nature of hospices is understood from the outset by everyone?
Yes. So I think within local structures, hospices need to be understood and valued, that they do provide an essential services for patients and families, and it needs to be clear how and where they access PPE, and we'll probably come on to talk about vaccination and testing as well, but how they are part of, or how the mechanism locally works to make sure that they have access to what they need. And I think because there was variation across Scotland, so in some areas it did work much better or it worked fine, so that shows it can work.
And you also mentioned that some hospices received donations of PPE that weren't actually suitable for hospice use. Could you explain why they weren't suitable?
I think I heard from some staff where, obviously the local communities were incredibly generous and businesses and everything, so they did receive a lot of donations. I think some had mentioned that visors had gaps in, or masks that were homemade weren't suitable for them to use always, but other donations would have been, and they certainly, I remember one hospice saying that their local dentist offered supplies for PPE when it was announced that dentists were closing, and then they were like, oh right, we're going to now phone around all the dentists in our local area and get supplies from PPE that way. But for some hospices it was a constant juggle and trying to get access to the PPE they needed.
You also mentioned that there were issues, delays of weeks or months for staff to get their vaccines because they weren't initially on the NHS booking system. Did that impact the care they were able to provide to patients?
I don't know if it changed the care that they were able to provide, but it meant their staff weren't supported and protected in the same way that NHS staff were. So perhaps I don't know what there were higher levels of sickness or anything, but it meant their staff weren't protected in the same way, and perhaps they would have to isolate more. And I think the vaccination, that's another example where in some parts of Scotland and for some hospices it did work well, and they were able to access vaccinations at the same time as NHS staff, and that worked fine. But then in others, we'd got confirmation from the Scottish Government that hospices should be included in health and care staff and the guidance around vaccinations, but locally the mechanism wasn't there, so they might have needed an NHS email address to access the booking system, but they didn't have that. So then, but no one had thought about that in advance, so they had to, again, it's like who you knew or your local networks, or you just happen to hear there's slots available, and then the hospice can try and find staff to fill them. So some staff said it felt a bit shambolic or chaotic, and it wasn't a structured process in some areas.
So that's perhaps another learning point, that when these things are being rolled out, they look beyond just NHS email addresses and so on, and include others.
And recognise again that it's hospices and voluntary sectors are providing vital care and support. So as well as statutory services, NHS services think across the whole system and the different sectors that provide care, and how practically can you support staff working in those sectors.
Thank you. And you mentioned under heading 7 that initially some hospices stopped visitation altogether. Given that family members wouldn't be there to assist patients perhaps, how did that affect overall staff workloads? Did staff have more responsibilities then at that point, or?
If there were restrictions to
Yes, if
visiting.
family members weren't able to visit patients in hospices, did that impact staff work levels?
So the majority of hospices did continue visiting throughout the pandemic. There were a minority of hospice services at the very start of the pandemic who, when they're trying to interpret the guidance and work out how they could do this, allow visiting safely for patients and families, they were trying to work out the best way to do that. So there were a small minority where that was stopped. The changes, sort of restrictions to visiting, that is certainly the area that had the biggest impact on patients, on families and on staff. So it's the area that people talk about with the most distress, certainly. I don't know, in terms of the impact your specific question was around workloads. So it certainly impacted the working environment that staff worked in and how they felt about it. And you might well come on to that separately. I don't know if it created more work. I know they would have to. They did some staff in inpatient units did say if patients weren't having the same level of visitors because of the restrictions or that was restricted, that they would be working in different ways. So they would be trying to provide more support for that patient because they're not having the visitors coming in, that they would spend a lot of time sitting down with them and talked about like making gifts for family members or writing letters. They talked about trying to facilitate FaceTime calls as well, but actually how hard that can be sometimes, just some of the logistics of it and how distressing it is when it takes multiple attempts for a family member to actually connect with the patient in it. So it probably did have an impact on their workload or the way they were working, but the greater impact was the distress caused to patients and families and staff.
And in the case of the hospices that did stop visitation altogether, was that a consequence of their interpretation of the guidance, or did they think that the guidance wasn't adequate and they wanted to take these extra measures?
I think the ones when they've shared with me what happened, it was about them trying to work out how they could continue to allow visiting safely. And also, one said that they were trying to follow the ethos of the narrative at the time, which was to minimise contact and protect the NHS. There was different interpretations of the visiting guidance, so different hospices would interpret it differently and would allow different levels of visiting in terms of how many people could visit, if that's one or if that's two, for the length of time that they could visit, whether it's a named person. But that's also partly because, hospices, again, they're all different. They're all independent organisations. Their buildings are very different. Yes. So some have, lovely new shiny buildings which have direct access from patient rooms to the outside. They've got more single occupancy rooms, so perhaps it's easier, but it was easier for them to facilitate visiting in a safer way compared to others, perhaps in older buildings or more multiple occupancy rooms. But absolutely, hospices were trying to do the best that they could for patients and families, and they know how important the support for families are at the end of life and maintaining those contacts. So they were trying to do everything they possibly could to facilitate that within the constraints during the pandemic.
15 minutes, Ms. Rami.
Thank you, my lord. You've mentioned that the visitation not being allowed particularly had an impact on the psychological well-being of patients and their families. Were you told about any specific examples of situations where this arose? Are you aware of any instances that were particularly difficult for individuals?
I think, staff did talk about specific examples. I think it's the kind of thing that just really stuck with them. The whole ethos of hospice and palliative care is that you do everything you possibly can to support the individual and their families. So hospice staff are used to bending over backwards for patients and families, and they talked about, they're seen as enablers, but then all of a sudden they felt like they were gatekeepers and they were having to prevent that, and they found that very distressing. Yeah. I think some of the examples that they gave were an individual who has 3 grown-up children, but their visiting policy at that point in time was just to allow 2 people to visit at the end of life, and then how does anyone make that decision? They found that very challenging, and that patients and family members would challenge them on decisions, and hospice staff aren't used to having those conversations. So there were specific examples which have clearly stayed with staff and very much impacted them and were distressing.
Does Hospice UK have a view on whether visitation rights at the end of life should be enshrined in law?
I think some of the learning from the pandemic is just how important it is to maintain contact with families and loved ones. We don't have a specific view around whether enshrining this in law is the best way to go about it. I think we'd have to look at if there were specific proposals, look at the detail in that and think about how that would apply to the hospice setting. I think whatever mechanism there would be, it needs to maintain the person-centred approach and keep the flexibility and make sure that hospice staff would still be able to make decisions based on their own judgment and on the individual circumstances of that patient and their family.
Now, under heading 8, you state that there was a lot of uncertainty at the start, and staff were having to adjust to different sets of expectations, but that some frontline staff felt they were working with their hands tied behind their backs, not being able to make their own decisions or have agency in their roles. Could you explain or give examples of what's meant here?
So that's kind of like what I was just talking about with the visiting, where them as palliative care professionals pride themselves in being very person-centred and very holistic in their approach. But because of the constraints and the restrictions, they were unable to care for patients and their loved ones in the way that they are used to and that they would have liked to do. And that might be around visiting. It's also things like just wearing all the PPE makes communication difficult, not being able to touch people in the same way, just having to work in a very controlled, very different environment, staff said was very challenging and sort of challenged the whole ethos of palliative care and how they pride themselves as hospice care staff.
And you go on later to talk about families feeling abandoned by health professionals and hospice referrals going down potentially as a result of people not seeking the support they needed, and so consequently changes in condition not being picked up or acted upon. Does Hospice UK or any of the member hospices have thoughts on how this could be addressed and avoided in future?
I mean, I think it's a really big question, a really important question. I think there's something around making sure that hospices are integrated into the wider health and care system, that people aren't missed. I think it was for different reasons as well. So, there was a fear factor there of people not wanting perhaps to go to their doctor. It's also around they couldn't get GP appointments or speak to their GP. There's lots of different perhaps reasons of why it is, but we know how important it is that people are seen and that they get the support that they need. We know how important early intervention is in palliative care. So I think there needs to be learning from it, and it needs to be prioritised going forward.
In the final paragraph under heading 9, you say that poor communication by some care professionals was demonstrated by a number of things, including the inappropriate use of DNA CPR orders. Could you expand on the inappropriate use, and are you able to give any examples of inappropriate use?
I think so. This came from one of our member services that they had. I think they'd seen it within care homes. I think there's definitely there's strong evidence in terms of how important it is that there is advanced care planning or future care planning, like people are thinking ahead to what their needs are at the end of life, and that includes looking at DNA CPRs. But during the pandemic, I think it was hard with everything happening for clinicians to always have those conversations with patients and families. So the examples which I heard from these members of staff was that they had seen examples where that didn't happen, and then it was left to social care staff to have these conversations with patients and with families, but that they hadn't been supported to have these really difficult conversations. So they weren't handled in the best way, and that did have an impact on patients and on families and on staff themselves, and did cause distress. So I think it goes back to, generally needing to be more open around death, dying and bereavement and having those conversations, but also making sure that staff across all settings are supported and have training in how to do that.
And on the topic of communication, you also state there that it was hard for patients and families to not be able to speak with or get the information they wanted from wider health and care professionals. Why weren't they able to speak to those professionals or get the information they needed?
I don't think I can speak for other professionals. I certainly, the examples that hospice staff shared with me, and I don't know how widespread this is or if it is an issue across Scotland, but certainly that it could be challenging for patients to access their GP. So one talked about a patient having to wait 17 hours to speak to their GP, and that GPs weren't doing home visits. And I know there were issues around social care support as well. And I think services, so community services, were under enormous pressure. So with sort of the shift in where people were being cared for, that has a natural knock-on effect to services and staff. But hospice staff did really feel that that has had a long-term impact on patients and families, and that some talked about a breakdown of trust with healthcare professionals, and that the lack of communication and people being worried that their loved one, their care was missed, or they didn't get the care and the support that they needed, and that's had a real long-term impact on sort of people's bereavement and grief, and just their feelings towards healthcare professionals and their sort of resilience and mental health.
And on the
Ms. Rami, you've only got 5 minutes, I have to tell you.
Yes, my lord, thank you. On the issue of things being missed, you raised the issue of late diagnoses. You state that hospices saw people being diagnosed and given a terminal diagnosis much later in their disease trajectory, with far more people in their 30s and 40s having terminal conditions. Presumably prior to screenings being suspended or cancelled, people of those ages would have had their conditions caught at an earlier stage. I wonder if that's correct, and if it is correct, whether Hospice UK and the individual hospices perhaps have a view on whether such screenings should be prioritised and permitted to continue without interruption in the event of another pandemic?
I think so. So staff consistently, hospice staff have consistently said to me, yes, they are now seeing, as you were saying, patients who have been diagnosed late. They're seeing younger patients. And I think that's probably for a variety of reasons. So I think we know people weren't able to access the services and treatments that they did prior to the pandemic. We know that things were potentially missed. You talk about screening, even things like moving more to virtual consultations and support. I think it's harder sometimes to pick up on things. Certainly some staff have raised that. So I think it's, again, there does need to be learning from that and the impact that we've seen from the pandemic, and think about how we can prioritise making sure that everyone gets access to the care that they need. And I've said before how with palliative care, early intervention is really important, or certainly staff said, yes, they have seen patients that they felt like perhaps if it had been picked up earlier, that individual wouldn't have been in that situation. So yes, I think it does need to be prioritised going forward.
Thank you. I wonder, is there anything that we haven't covered today that you would like to highlight or emphasise at this point?
I think just the final thing is, to me, I'm not frontline staff, but I work very closely with them. I'm just really impressed by how the hospice sector did step up, how they did continue delivering care to patients and families in very challenging circumstances. And I think that there's learning to be had, not just, if there was another pandemic, but actually in Scotland there is there's population changing happening. There is an increased need in palliative care. How will we be able to respond to that growing need for palliative care? Like, what learning can there be from how we had to respond to the increased need during COVID? How can we also apply that to the growing need for palliative care and all the services that provide that vital support, including hospice care?
Thank you very much.
Thank you.
Yes, thank you indeed very much, Ms. Malo. Very grateful. Tomorrow morning at 9:45.
Thank you, my lord.